Hello, everyone, and welcome to another UCARE LevelUp webinar. It's great to be here with you all. So let us just start our amazing webinar with an amazing, quite stellar panel. Honestly, I'm really honored to be in the mix of all these amazing ladies here. So, our webinar is about solar urticaria, diagnosis, management, and treatment for physicians. I'm João Marcelino. I'll be your basic host for today, and the main talkers here today will be Sheila McSweeney, Lea Kiefer, and Lesley Rhodes, and I'll present them each one before their respective talks, and you'll see just how amazing these women truly are. I would also like to thank everyone who's been a part of our UCare family. We are 218 registered users, 53 countries all over the world, truly from Europe, all over Europe, which is amazing. South America with a huge amount of centers in Brazil, also Asia, Africa as well. North America is also a big part of our big family, also New Zealand. So I want to thank each and every one of you for being a part of this UCare and family, which is a growing family, which will keep us all giving us all new information, new data, and further knowledge to our patients and to ourselves. So, in terms of today, we'll talk about solar urticaria. I'll do a small introduction with the definition, epidemiology, and patient impact of solar urticaria. There will be a talk by Sheila McSweeney on the pathophysiology and triggers and genetics. A second talk by Lea Kiefer on the clinical presentation and diagnostic approaches. And the last talk on the pharmacologic and non-pharmacologic treatment of solar urticaria by Lesley Rhodes. I also would like to remind everyone that this is a CME accredited webinar, so you need to be present and attend the whole webinar, and to please don't forget to answer the questionnaire at the end so you can get this CME accreditation. Also, here is our link for basically all our social media channels. Please make sure you're a part of our channels, following us up, and being a part of all our outreach. And if you have any questions, please leave it on the Q box on the Zoom window. And at the end of each talk, we'll see your questions um, and ask the presenters for each to answer each of those questions. So please do not be shy and have fun like we are going to be having. And please also stay connected to us. You can scan this QR code and be on all our social media websites. So, starting off, the relevance of solar urticaria in practice, definition, epidemiology, and patients. What is solar urticaria, basically? So, solar urticaria is a rare photodermatosis characterized by cutaneous mast cell degranulation and formation of itchy wheals and/or angioedema. And this happens following the exposure to specific wavelengths of electromagnetic radiation, which basically means UV, UVA, UVB, and also visible light. However, this definition doesn't really tell us much about the underlying mechanisms which caused solar urticaria. So if we will try to be a little bit more informative, one could say that it's a rare IgE-mediated chromophore-dependent photodermatosis. But what is this? and hopefully we'll find out on our talks today. And here you have the perfect example of a solar urticaria patient. You see that this gentleman had a shirt on when he came to our clinic and also had a necklace, and you see that those areas are normal skinned, and all the rest of the areas which were exposed to the sun outside, he got really strong erythema. So, solar urticaria, it's a rare disease, as I said. It's between 0.086% and 0.4% of all urticarias, and between 0.7 and up to almost 18% of all photodermatosis evaluated at a hospital setting. However, data is very limited. Solar urticaria has been described mainly by single-center observational studies, and a systemic review into 2023 compiled only a total of under 19 solar urticaria cases. So we are talking about a fairly rare disease, or at least underreported one. An important point on the epidemiology is that it incorporates all ages, both genders, and skin phototypes. It usually affects more women between the ages of 20 and 40, but it affects all ages. And just to show be a little bit more specific about this, I can present this data from a UK multicenter cross-sectional study presented in 2024 of 178 solar urticaria individuals. And basically what I want to stress is that it happens in all races, even though this is a UK review, it has not only European, but South Asian, East Asian, African. So it affects all ages and accordingly all skin phototypes. So let us not think that it's only fair-skinned people that have this. No, black-skinned people can also have solar urticaria. In terms of patient impact, I'm just going to show this very small study. They did it also in the UK with 145 patients, and 66 of them failed the DLQI regarding their solar urticaria in the past week and the past year. And here's the results. Basically, as you can see, we have the 10 questions of the questionnaire of the LQI, and we see that all of them had an average of over 1, which when we look at the overall impact in the DLQI, we see that for the past week, 56% had high or very high impact with a mean score of 11.1. And if we looked at the past year, almost 70% high to very high with a mean of 12.5, which is an amazing high impact to find in urticaria patients. So yes, solar urticaria is very important and has quite a high impact on our patients. So without further ado, let us start our webinar. We'll start with Sheila McSweeney. She's currently a resident doctor in dermatology at St. John's Institute of Dermatology in London. She has an interest in immune-mediated inflammatory and photosensitive skin diseases and has completed a PhD investigating the genetic etiology of solar urticaria. Sheila, the floor is yours.
Thank you very much for that lovely introduction. I'm just going to share my screen and I think we'll be able to. So my name's Sheila and I'm really glad to be here presenting on solar urticaria mechanisms and provoking factors. So just to say first, I have no conflicts of interest to declare. And then to start thinking about solar urticaria pathogenesis, I think a really interesting place to start is to think about the wavelengths or wave bands of solar electromagnetic radiation that trigger solar urticaria, because this can provide us with some preliminary insights into what might be driving this disease. Now, this bar chart here summarizes the frequency of reported wave bands that trigger solar urticaria in that 2023 systematic review incorporating about 900 solar urticaria patients. So what is readily apparent from this bar chart is that solar urticaria is actually most commonly triggered in patients by visible light alone. But when you look across the spectrum of this bar chart, you can see that some patients are triggered by ultraviolet A alone, some by ultraviolet B alone, some by visible light alone, as we've already said, or any combination of these three wave bands. So there's really quite a lot of inter-individual variation. And what's quite intriguing about this feature of solar urticaria is actually this broad range of kind of triggering wavelengths or wave bands is very different to other photosensitive skin diseases. So, for example, with photosensitive drug eruptions, it's typically a very narrow range of wavelengths that triggers the photosensitive drug eruption. And so solar urticaria is very unique in this regard. So what does this feature of solar urticaria tell us about its pathophysiology? Well, to understand this, we kind of have to think about some basic photobiological principles. So we know from basic photobiology that photobiological processes, so molecular changes in the skin caused by sunlight, are typically triggered by a very specific interaction between a wavelength of solar radiation and a specific molecule. And in the photobiology field, this specific molecule is known as a chromophore. And I think what we can infer from the broad range of triggering wavelengths that we see in solar urticaria is that there may well be multiple chromophores that are responsible for solar urticaria pathogenesis. However, what this kind of feature of solar urticaria doesn't tell us is how or why mast cells activate in response to solar radiation in solar urticaria. But that is a question I'll try to address later in this talk. So what we do know about the chromophores in solar urticaria is derived from what are called passive transfer experiments. And these were experiments performed between the mid to late 20th century. And what they involved is taking blood from a solar urticaria patient, extracting the serum, injecting that serum under the skin of a healthy volunteer, and then shining light on the skin of that healthy volunteer. And in many instances, this procedure actually reproduced the symptoms of solar urticaria in that healthy volunteer. Now, based on these observations of positive passive transfer of solar urticaria, investigators concluded that there must be some kind of serum factor representing a chromophore in the blood of solar urticaria patients that can be passed from patient to healthy volunteer. Now, for ethical reasons, these experiments are no longer performed in the current kind of later 20th century, 21st century. But before these experiments were considered unethical, several iterations of the passive transfer experiment did allow us to partially characterize some of these potential chromophores in solar urticaria. So one of these iterations was performed by an investigator called SAMS, who basically performed a passive transfer test using specific fractions of protein from patient serum. And by specific fractions of patient serum, I mean that he separated solar urticaria patient serum into kind of globulin and albumin fractions and even subfractions of those particular fractions. And again, he performed a passive transfer test and was able to reproduce solar urticaria in healthy volunteers. And this diagram here just illustrates one of the experiments that he performed, where he was passive transferring kind of subfractions of the globulin fraction of solar urticaria patient serum. And basically, through a series of experiments whereby he demonstrated that the globulin and albumin fraction of blood could result in passive transfer of solar urticaria symptoms from a patient to a healthy volunteer, he concluded that an allergic antibody or antigen must be responsible for solar urticaria symptoms. And also he tried to passively transfer subfractions of the globulin fraction, so the IgG and IgM subfraction of the globulin fraction of patient serum. And because passive transfer wasn't successful in this particular instance, he concluded that neither IgG or IgM were responsible for passive transfer of solar urticaria symptoms. And he inferred from that that it must be IgE that is responsible for the passive transfer of solar urticaria symptoms. In addition, a lot of studies were performed by a Japanese group led by Kojima et al., and they performed an iteration of the passive transfer test known as the in vitro activation test. And again, they took solar urticaria patient serum. And what they did was they separated the proteins in the patient serum according to their molecular weights, and then transferred different fractions of serum containing protein of different molecular weights into healthy volunteers to achieve passive transfer. And again, we can see a diagram representing their experiments here. And what's quite intriguing about the experiments performed by Kojima et al. Is actually that they were able to demonstrate that proteins with highly divergent molecular weights were capable of passively transferring solar urticaria from patients to healthy volunteers. So these experiments have effectively formed the basis of our understanding of solar urticaria to date. There exists effectively a photoallergy model of disease where there is some kind of cutaneous chromophore, whether that's an antigen or an antibody, that becomes activated in the context of some kind of ultraviolet A, ultraviolet B, or visible light. And this leads to presumed IgE-dependent mast cell degranulation with release of histamine, heparins, cytokines, and proteases that result in the symptoms that our patients report. And this is really where our understanding of solar urticaria has stood for a very long time, because the passive transfer experiments couldn't be repeated anymore, and there wasn't a lot of investigation of the disease. One particular author, Li Nutafong, did try and kind of promote our understanding of solar urticaria by summarizing all the passive transfer experiments that were reported in the literature. And he classified solar urticaria into two potential subtypes based on the results of passive transfer experiments. Type 1, basically, he felt that this type of solar urticaria may be one where there's an abnormal chromophore expressed by the SU patient in their skin, and this is responsible for symptoms. And also, he thought there might be a type 2 where there is some kind of abnormal autoreactive IgE expressed by the SU patient that is responsible for their symptoms. And that's really where we've stood up until very recently. However, I think we're in a really exciting era for solar urticaria, as there's been a lot of interest in investigating its pathogenesis. And this sort of movement has really been spearheaded by Kirsty Rutter and Prof. Lesley Rhodes in Manchester. And we've begun to use genomic technologies to increase understanding of solar urticaria pathogenesis. So in Rutter et al.'s work, they took 4 solar urticaria patients, and they also took age, sex, and skin phototype matched healthy controls. The patients underwent photoprovocation with 10 joules per centimeter squared of solar simulated radiation. And then skin biopsies were taken from irradiated lesional skin and also non-irradiated non-lesional skin for bulk RNA sequencing and also histological analyses. And this slide here summarizes some of the really interesting results from that particular experiment. So in the first instance, the bulk RNA sequencing analyses using ingenuity pathway analysis, Rutter et al. Were able to show that there was significant upregulation of several pro-inflammatory pathways in the 30 minutes following solar urticaria propagation, with some of the most upregulated pathways including granulocyte adhesion and diapedesis. In addition, they did analysis of activated genes and upstream regulators of these particular pathways. And what they identified was that one of the upstream regulators was IgE and the high affinity IgE receptor, so implicating potentially IgE-dependent mast cell activation. And also they showed activation of STAT3, which is a downstream intracellular signaling molecule that exists kind of downstream of this high affinity IgE receptor. And to really kind of emphasize the point that solar urticaria, it could be triggered by IgE-dependent mast cell activation, they did co-staining of mast cells in the solar urticaria patient's skin, and were able to demonstrate that basically the mast cells were upregulating phosphorylated STAT3. So phosphorylated STAT3 is activated STAT3 within 30 minutes of solar urticaria provocation, really kind of strongly indicating that it may well be an IgE-dependent process ongoing in solar urticaria. So that brings me to the end of this summary of what we know so far about solar urticaria. Our main learning points. I think it's very clear that there are a broad range of triggering wavebands or wavelengths in solar urticaria, and this implies that multiple chromophores or molecules in the skin might be involved in triggering solar urticaria. There is definitely increasing evidence supporting IgE-dependent mast cell activation as a mode of mast cell activation in solar urticaria. However, precisely the connection between solar radiation exposure and IgE-dependent mast cell activation in solar urticaria is as yet unclear, and it really will be a focus of future investigation in this intriguing disease. Many thanks for your attention, and I'd be delighted to take any questions.
Sheila, thank you for this amazing review of the pathophysiology. I would like to ask you, it's a kind of a tongue-in-cheek question here, but how far do you think we are from start identifying some of the chromophores that might be involved in solar urticaria?
I think we're closer than you think, actually. I think because we have so many technologies and techniques available to us these days. So, from kind of the genomic technology perspective, we have all the sequencing technologies. So we can look at the genetics of solar urticaria. We have really advanced and granular RNA sequencing technologies now. So we can do bulk RNA sequencing, single cell RNA sequencing, spatial transcriptomics. And then even our advances in terms of wet lab kind of mast cell biology investigations, which the Charité are really experts in. I think we're really close there in terms of being able to maybe extract kind of intercellular fluid, analyze the contents, and analyze those contents in a really kind of detailed way. So I think actually this could be a really, really exciting time, both for kind of understanding solar urticaria and the chromophores, and also understanding sort of immune-mediated inflammatory kind of photosensitive skin diseases.
Okay. Let me just see. So we have here some questions. The good response to omalizumab support the IgE-mediated pathomechanism. Do you agree? And do you ever think about the tisular or circulating autoantigen in terms of the origin of these chromophores?
Mm-hmm. So with regard to omalizumab, I agree. And I think until Prof. Rhodes did her work, I would have said the two kind of experiments that implicated IgE in solar urticaria was that sort of indirect experiment by Sands et al. And also the fact that omalizumab works in solar urticaria. The only caveat to the solar urticaria question in my mind is that although omalizumab is an anti-IgE monoclonal antibody, we technically don't know, is it just its anti-IgE effects or does it have other modulatory effects? So I think that kind of keeps the question a little bit open. So I hope that kind of, it's a little bit of a, I'm sort of hedging my bets a little bit, but that's probably the honest answer. And then could you remind me of the second question?
Do you think it's more probable to have a tisular or circulating autoantigen as the origin of this chromophore?
I think it is possible for it to be a circulating autoantigen. Although I would have said if it was circulating, I would expect far more kind of systemic autoimmunity, potentially in solar urticaria. We know there's a bit of an overlap where some lupus patients will have solar urticaria type symptoms, and also some patients with kind of true solar urticaria might carry quite a lot of autoantibodies without maybe many systemic manifestations. So I think it's possible. But I do often think of the skin immune system as being a little bit more separate from other immune compartments. And we recognize this, I think, in kind of eczema and stuff like that, where you don't get huge kind of blood, clinically, you don't get huge blood related pro-inflammatory markers and stuff like that. Compared to, say, diseases like rheumatoid arthritis or lupus, where you get massive changes in normal blood parameters from systemic disease. So I think it's possible, but my money would be a little bit more on the skin.
On the skin. Okay. Thank you, Sheila, so much. I can say for myself, I learned a lot from you today. So we'll move on. I'll just answer this last question. As Sheila said, yes, there's a broad wavelength of light that can trigger the solar urticaria. So now we'll talk with Dr. Lea Kiefer, Senior Dermatology Resident at Charité UCARE Center. She's specialized in clinical research on solar urticaria and other forms of urticaria, and she currently is running the solar urticaria and erythropoietic porphyria program at Charité in Berlin. Lea, we are hungry for your knowledge.
Thank you very much for your introduction. I'll start sharing my screen. I guess you're all able to see it. Okay, so today I will give an overview about the clinical presentation and the diagnostic approaches that also quite vary between centers, and by this, also giving points that are important about history, testing, and of course the differential diagnosis that have to be considered from the photodermatosis, but also from the chronic inducible urticaria side. I have no conflict of interest to declare, and I want to start with the clinical presentation. And starting from the clinical presentation, we heard a little about it, and wheeling is also important and occurs in most patients, but there's also a lot of patients that report erythema or like a really low level wheal. Most patients report itching, or all patients itching or burning, and there's a small percentage with angioedema. Basically from the numbers, which was also nicely worked from work from Sheila, most patients report an onset below 15 minutes after sun exposure, and the resolution in patients is usually about 1 hour after stopping. There are also patients that report a shorter resolution, or also longer, a few hours, but it shouldn't be over 24 hours. Symptoms can occur through closing. This is mostly because of the type of the closing that the light can go through, or also which leads from the diagnostic perspective, it can go through class. So we have to think about UVA, which is also for other forms of photodermatosis, and also for not so much for the CINDUs, is the phenomenon of hardening. So patients over time, like in springtime, experience worse symptoms than in the end. This of course doesn't account for every patient, but patients report it. And which is always important to ask is systemic symptoms, because there are patients, even if there are not many, but the disease is rare, so of course there's a low number. Nauseous, dizziness, due to the fact that some experience anaphylaxis, and this obviously leads to adaptation for treatment and management. To continue, the history has been taken very thoroughly, and we can already, like by asking the questions, continue to make the diagnosis or to narrow the diagnosis. And the first question from, of course, like, can you make your wheals come? And then how? And in this case for solar urticaria, then the next question should also be like, how long after sun exposure do the symptoms occur? So time of onset. Then where are the changes located? Whether obviously like exposed skin or not exposed skin, and how do they look like? How they feel? Are they itchy? Do they burn? And then, which leads to the next very important question: how long do the symptoms last after onset? And by like the first and the third question on the slide, we can already narrow the diagnosis for diagnostic purposes. Then photosensitizing medication are common, or there are some that are broadly given, so this needs to be asked and ruled out. Comorbidities, especially allergies, atopic dermatitis from this side, but also other photodermatosis or autoimmune diseases such as lupus. Are the symptoms weather dependent, or do they worsen and improve seasonally? Of course, solar urticaria, whether like if it's really rainy, like cloudy outside, it could lead to less symptoms, and the season again leads to the like explanation of the hardening phenomenon. Occurrence in childhood, yes, especially like if there are some other differential diagnoses, for example, erythropoietic protoporphyria. This has also a sudden onset after exposure, but usually occurs early in childhood since it's a genetic hereditary disease. And what we already mentioned is the high impact on quality of life of patients. So this should be also one of the important questions to ask. There are obviously more, but I wanted to highlight those that also lead to the diagnosis. In terms of guidelines, we have some recommendations for chronic inducible urticaria, and here it's on the left slide you see an algorithm where it starts with a question: can you provoke the wheal? Then how can you provoke the wheal? Then the provocation testing. In this case, it would be photoprovocation, and if it's provoked, we consider it the typical form. But there are forms of CINDU that do not, are not provoked by our provocations method, so they are then considered as atypical. There's also the recommendation to assess disease activity and control. So far, we have the urtical control test, which is validated for CINDU. So this should be applied initially when patients present, and then also as a follow-up for diagnostic and also therapeutic monitoring. I want to continue with the laboratory workup, and main part of it is close to the recommendations for chronic inducible urticaria, so differential blood count, inflammatory parameters, total IgE, which is also has been shown to be elevated in a lot of SOLU patients, anti-IgG, anti-TPO, porphyrines. We do it here in our center as it's suspected, and vitamin D that has been shown to be low in a lot of photodermatosis patients, also by work of Professor Rhodes and colleagues. But the most important for diagnostic is the photoprovocation. And also here we have the recommendations by our guidelines to provoke with a device that contains UV and visible light of different wavelengths, and do a threshold test, as well as to rule out other photodermatosis by the history and by the testing. The main aims for the photoprovocation is to define the trigger. So in this type of CINDU, the action spectrum from UVA, UVB, visible light, and which is also important to stop which is clear, but the patients have to be always reminded to stop medication before the diagnostic provocation. An average 5 half-lives, so most are antihistamines, so 3 days should be fine. To continue with types of photoprovocation, as I already mentioned, photoprovocation devices and protocols vary between centers, and here's an overview what kind of devices can be used. And on the left side, you see monochromator devices that can trigger like different specific wavelengths. And on the right side, there are the UVA, UVB light sources that do not differ between the specific wavelengths, and the solar simulator to provoke without if you use it without filter between the wavelengths. The protocols, one on the right side that is recommended by the guideline is mainly covering the handheld devices, and then on the left side you see a back of a patient who has been provoked with a monochromator, and you see here already the difference in protocols, and the main aspect is here to provocate, like on the right, UVA, UVB, visible light, but of course you get a more definite and concrete definition of the wavelengths that are provoked by a monochromator testing. To continue with the differential diagnosis, and I like this slide because it goes back to one of the key questions for the history, and shows that time to eruption, minutes, when do the wheals appear lead to already narrow the diagnosis to solar urticaria and erythropoietic protoporphyria. But then if you ask for the resolution, one can already narrow the diagnosis for solar urticaria. Then if we look at other photodermatosis that take a longer time to eruption, like ours, for example, photopolymorphic light eruption, photoallergy, chronic actinic dermatitis, heterovacciniforme, it take longer to appear, but also take longer to resolve if you see the duration resolution part. Then, not to forget lupus, that takes up to weeks, and porphyria cutanea tarda that also stay there chronically. The next slide shows on the left some, again, photodermatosis, differential diagnosis, heterovacciniforme, chronic actinic dermatitis, polymorphic light eruption. And on the right, I also wanted to point out the differential diagnosis for CIndU, because also patients, when they do, for example, sports outside, and they always have the symptoms there, we should also ask about cholinergic urticaria as well, for cold urticaria that has a high temperature threshold, also warm urticaria, which is also rare, to provocate and rule out those. I'm at the end of my talk, and I want to point out my key points. For history, it is very important to ask for the trigger time, onset, and offset. For photoprovocation, UV light and visible light of different wavelengths and the threshold should be tested, and other photodermatosis and chronic inducible urticaria should be ruled out. And the last point, we need a standardized photoprovocation protocol to use and to help to further evaluate clinics. And I hope we can do this by all forced together. I'm at the end of my talk. Thank you very much for listening, and I'm looking forward to your questions and the discussion.
Okay, Leah, thank you so much. I think I'm going to start with a question from your last point. So, which wavelengths do you think we should use? Because as Sheila showed, we can have the whole spectrum causing this disease. So, are the ones that are present in our last guidelines from CINDU enough? Should we add more? What do you think?
So thank you for your question. This is very important, and of course we should, as given by the that it's most common, provocate UVA, visible light, UVB. However, to get a more precise answer, I think we need to even kind of narrow by monochromatic testing the wavelengths down. This is I was lucky to attend the clinic of Professor Rhodes and Dr. McSweeney, who do their monochromatic testing at their centers to narrow this down. And it's very interesting also for the clinic differentiation. But for the common use, I would say in a urticaria clinic, it's important to use really like UVA, you definitely, and if available, UVB and visible light. Yeah.
Okay. So we're going to make a couple of questions. One asking for your expertise on differential diagnosis on a patient with small macules on cheeks, especially on the sun-exposed side, persistent for a few weeks despite sunscreen 50 SPF, no systemic manifestations. Do you have any differential diagnosis apart from lupus in this case?
So small papules, macules,
On
I
cheeks, especially on the sun-exposed side.
How old did it say? How old
It
the
doesn't
patient
say.
was? So I would
What about
initially
systemic
say also
mastocytosis?
polymorphic light eruption because it's like the most common.
Okay.
And depending on the age and if other treatments have worked, narrow it further down, but it's hard to.
Now from Anna, do you think that general dermatologists will have serious problems to do a differential diagnosis between solar urticaria and certain polymorph light eruptions?
So I think if you really take time for the history and the patient is clear and like this is a rapid onset and offset, has pictures to show, and if a general dermatology clinic has the possibility to provocate, I think it's definitely possible. However, since not all cases are clear, it could be if it's like a more difficult case with maybe other diseases aside, other photodermatosis, it could be hard, and definitely I would always say to send the patient to a specialized center because just of the equipment and differential diagnosis that can be tested, it can be hard. Yeah.
And the final question, do you think how necessary do you think it is for us to ask about clinical hypothyroidism, other autoimmune diseases, concomitant with the solar urticaria?
I think it's important to ask because it's like all also from chronic urticaria, from other chronic inducible urticaria, and solar urticaria. These diseases often coexist, so we get a broader and bigger picture, and may helpful for therapy and management for the patient.
Okay. Thank you so much for your expertise. Now to our final panelist, Lesley Rhodes. She's a professor of dermatology and photobiology at the University of Manchester in the UK. She is the founder and director of a major unit for diagnosis, treatment, training, and research into cutaneous photosensitivity disorders. She leads an NIHR research program examining the pathomechanisms and impacts of photodermatosis, notably solar urticaria. Professor Lesley, it's a great pleasure to have you here with us. So without further ado, the floor is yours.
Thank you. And it's a real delight to be following Sheila and Lea, who are two total rising stars, I should say shooting stars in photomedicine. It's wonderful to see the younger generation coming up. So these are my conflicts of interest. So we have some challenges in solar urticaria. The pathomechanisms, as we've seen, are still incompletely understood, and clinical trials are challenging to perform. It's a rare condition. It's dependent on UV and visible light exposure, which depends on season, time of day, weather, and there are as yet no specific prompts for solar urticaria. But there are also opportunities. Solar urticaria can be provoked in specialist clinics, giving us very detailed information on severity, thresholds, and wavelengths responsible, otherwise known as the action spectrum. And also, as Sheila showed, gives us the scope for a detailed study of very early molecular and cellular events. It's very hard to think of other disorders that you're allowed ethically to produce in our patients. So we are very privileged with solar urticaria and other photodermatoses. It's also an opportunity that SU often responds well to drugs trialled in the commoner CSU. So there are treatment opportunities, although they're often off license. Novel treatment approaches are emerging, and problems used in CSU and in dermatology can be useful. As we've seen, the pathomechanisms may be complex, not completely understood, but this is our sort of state of understanding or belief at the moment, that a chromophore absorbs the relevant wavelengths. The chromophore is then modified and triggers specific IgE binding to mast cells, activating the high affinity IgE receptor. Histamine and other mediators are released, and there's very early involvement of the innate immune pathways with early infiltration by neutrophils and eosinophils. And also earlier studies report circulating chromophores and autoantibodies. So what can we do to manage this? Minimize time outdoors. But this has a very high impact on life quality, especially as the condition takes only minutes to trigger, sometimes even less than a minute. Covering clothing, hats, wraparound sunglasses, UVR protective film for windows, particularly useful for the side windows of the car. Also, the avoidance of indoor lights emitting UVA. Topical sunscreens should take account of the action spectrum, which, as we've seen, varies between patients. Although it's true that the majority show the peak sensitivity at longer wavelength UVA, shorter vis. So chemical filters with absorption, including longer wavelength UVA, are important. And physical sunscreens may also include iron oxide to enhance the visible block, which is particularly tricky. Education in application method is also vital. Also, there's the synergistic effect of using topical broad spectrum, high SPF sunscreens and antihistamine. So on the left, you can see on the forearm there, we've got a broadband provocation, which nicely confirms the diagnosis. But the other two photos show what we can do with narrowband testing. And in particular, shows us the thresholds at different wavelengths through from UVA through visible. And also tells us the action spectrum. So that helps to guide us in the management of the patient. In 145 patients, we looked at the action spectrum, and I think you can see there that the top graph shows our own patients, 145 at the time, and the peak being at 400 nm, which is the borderline of visible UVA. And then below, we've combined that graph with graphs from other centres. And again, that sort of agrees, around 400 appears to be the peak. This is an older study that we did looking at how well patients apply their sunscreens and how we might help educate them. So we used a fluorescent sunscreen in order to map out a dose response for thickness of cream on the skin surface versus fluorescence. So we're able to quantify how much sunscreen was put to different areas of the skin. So in the middle graph on the left at baseline, you see that patients were applying the sun creams quite variably, and weren't hitting the dotted line, which is what the manufacturers use for their test conditions, a surface density of 2 milligrams per centimetre squared. But the dot in the middle was following one session of education, showing patients their results and how to improve on them. And then the last dot, I think you can see my mouse, that's 6 months later, without any further intervention. That one education section led to sustained improvement in the application of sunscreen, because there's no point having the best sunscreen in the world if you don't apply it well. Sorry, it's antihistamines. Second generation antihistamines are the first line treatment, second generation H1 antihistamines. This makes sense because of the evidence of histamine release, although they're not the only mediators involved. They have an excellent safety profile. You start at the standard dose, and then depending on response, can increase to 4 times the standard dose, according to published guidelines too. They appear beneficial in many SU patients, although with variable clinical efficacy. There was a recent Spanish study which showed initially complete resolution in 50% of patients, but this was only sustained in 30%. What about adding in a mast cell membrane stabilizing agent? It makes sense, but actually there's scant evidence available of benefit in solar urticaria due to lack of studies. Photochemotherapy. This can be approached with narrowband UVB, broadband UVB, broadband UVA, UVA1 and PUVA. And there may possibly be specific effects, such as altered mast cell membranes, so they release fewer mediators, or depletion of products. But on the other hand, there are the general effects of phototherapy with tanning, epidermal thickening and melanization, leading to less penetration of the rays, and the photoimmunosuppression that we all see, we all show on UV exposure. Rush hardening, this is not something I've actually done, but I was very interested to read more about it. So this can be done with broadband UVA and UVA1, but not with ultraviolet B because of the very high risk of burning the skin. So an example protocol was starting at 50% of the MUD, irradiating the body in quadrants, so not all at once, but with a very short interval between exposures, down to 15 minutes in one study, 60 minutes in some other studies, and other variations, for example, 3 times in a day, with 30% increments. But a maintenance dose is needed. It's clearly very laborious and, a little bit risky, may require hospitalization, at least to start off. Whereas an example protocol for narrowband UVB is quite similar to what's normally used in phototherapy, but again, you have to be well below the MUD. I've seen protocols for once a day exposure, then reducing to 3 times weekly, or even just starting 3 times weekly, with maintenance by sun exposure once you've got some basic hardening in the skin. But these are all based on case reports or very small case series, but several months resolution is possible. So it's worth considering. These are only just mentioned just very briefly, occasionally used approaches. Traditional immunosuppressives such as cyclosporin, mixed reports of benefit and fast relapse when you stop. Intravenous immunoglobulin, which obviously has infection risks with being a pooled plasma product, and very few studies, but some suggesting that multiple courses can give you prolonged remission, and I've observed that. Plasmapheresis for patients with a circulating factor. Serial treatments can be very effective, and I've also used that a few times in the past until the providers refused to provide it. You know, I had to go to a blood transfusion centre to beg for treatment for my patients. And ultimately they said, where's the randomised control study showing benefit? So that's the problem you can have with rare disorders. And then omalizumab came along, which has made a remarkable difference. In solar urticaria, it's off-licence use, but it's done so well. There's been such a collection of papers and studies that it's now recommended as second-line therapy in H1 antihistamine refractory solar urticaria. It's given as a monthly subcutaneous injection and can be updosed. A good safety profile and complete or partial remission in the majority, with systematic reviews showing around 70% responders and around 30% non-responders. So the patient in the middle is pretty typical of our patients with solar urticaria, and actually have to be said for the slideshow by all the other lecturers today. You know, we talk a lot about wheals, but actually what's often, frequently, you know, the most evident in the patients is this really widespread burning flare, with the wheals being a little bit less evident, but they're easily highlighted when you do the photoprovocation test. So those two arms there, that's somebody who was provoked by broadband UVA, with complete remission following omalizumab. So on the right-hand side, using that same dose of UVA, we were unable to provoke anything, when there's quite a beautiful, I think, square wheal with surrounding flare before treatment. And here we just looked at a range of parameters, only in a couple of patients. So the top left, you've got the UAS7, which we did separately for itch and flare. And basically the gaps between the bars are on treatment. So basically the scores were down to 0 on treatment. On the right, you've got the quality of life scores for urticaria and the DLQI, showing a major benefit there. And the patient at the bottom also showing a major benefit. This patient used to be totally wrapped up. He exposed no skin at all. It was covered in balaclava, and following treatment, he was able to reveal much more clothing. In fact, today, you know, these days, he's in shorts. But not all patients respond, and we don't fully understand the mechanisms. As Sheila kindly presented this, so you can see we can create our disorder. So unlike disorders like psoriasis, other, you know, skin disorders, we can actually provoke them with very low dose light. It is not traumatic. And that's shown by the healthy volunteers that we used. And this first transcriptomic study with follow through allowed us to study the evolving pathophysiology, and the findings basically demonstrating the high affinity IgE receptor as an upstream regulator, rapid activation of mast cell STAT3 well before keratinocyte STAT3, very early recruitment of neutrophils. So this sort of confirmed some proposed targets, but also highlighted potential new targets. And just very briefly, I'm going to mention MC1R agonists. These are promising drugs because they not only cause melanogenesis of the skin, but they also have antioxidant and anti-inflammatory activities. So basically, when light or UV rays hit the skin, they cause DNA damage in the keratinocytes. That leads on to synthesis of alpha MSH, which goes across into the melanocytes, where it induces melanogenesis. Melanosomes are formed, some of which then go back to protect the keratinocyte nuclei from further damage. So alpha MSH is being made, which is a highly protective factor. Wouldn't it be neat if we could just give the middleman, let's just give the alpha MSH, not bother with the damaging UV. However, alpha MSH has a very short half-life, and that's why analogues of alpha MSH have been developed, and more are being developed. So this is afamelanotide, it's a super potent analog which stimulates the MC1R for much longer than alpha MSH. And amazingly, it causes tanning in skin type 1 and 2, who normally don't tan at all or very minimally. And the other great thing about this is that melanin reduces the penetration of both visible and ultraviolet radiation, so where sunscreen may not be as effective. So we did a small open study, but because of our very detailed testing methods, we were able to show not only the minimal urticarial dose at each wavelength, but also we measured the area of the wheal and flare. So these patients were given one implant of afamelanotide at the start, and then we repeated the monochromator, the narrowband testing at 1 month and 3 months. And this showed a substantial reduction in both wheal and flare that was prolonged out the 2 months. Clearly, we need further studies. So, learning points from today. Second generation H1 antihistamines are the first line treatment. Omalizumab is regarded as the second line treatment. Broadband UVA and UVA1 can be used in rush hardening phototherapy. Thank you.
Thank you, Lesley. Such an valuable talk from you. We'll just have time for one question from Anna. She has experience with solar urticaria in more than 20 patients in Barcelona who are refractory to H1 antihistamines and skin hardening. And omalizumab was extremely useful, but the patients cannot stop. They relapse. Is that your experience as well? And is there a way to obtain complete control, remission with no relapse? Is there any UCARE project on the horizon for this?
Omalizumab, in our hands, has controlled every patient to some degree, some totally, but they are dependent on it. So it's analogous to treating CSU or treating psoriasis or eczema with monoclonals. You don't get a cure, but you can get extremely good control.
And is there any cure on the horizon or any projects searching for this?
Well, I mean, our study has been looking at the very early molecular and cellular events. And I think we should probably try to get together with industry a bit and talk about our findings and how they could be exploited. When it comes back to old-fashioned treatments, plasmapheresis, I found in the past, could give very prolonged control. It's just that it's too complicated. I saw people actually go into remission for a couple of years or even more following that. So, but then again, that's just a case experience, isn't it? It's not a randomized controlled trial. So no, I don't know of anything that will cure solar urticaria, but I don't know of anything that will cure most diseases affecting humans. We can control, we rarely cure.
Okay. Thank you so much, Professor Rhodes, and thanks to everyone who is following us in this webinar. Thanks again to Dr. Sheila McSweeney, Dr. Lea Kiefer, and again, Professor Rhodes. And to finish up our webinar, I would just like to please remember you to fill this form so you can have your credit point from this webinar. Please stay connected to us. Use this QR code to follow us on all our social media platforms. Please do attend and do register for our next webinar on endotyping of chronic urticaria. Where do we stand? And we have an amazing panel here again. Murat, Emek, Martin, you could hardly ask for better panelists for this next webinar. Please do register. Register here, use this QR code. It's on the 29th of April. And thank you all again for participating, and thanks again to our sponsors who make this webinar series possible. So to everyone, thank you and have a good day.